Hey, everybody. Welcome back to the You Are Not Broken podcast. Today, I have Jennifer Lanoff, who's a board-certified women's health nurse practitioner and attorney, and we're going to hear all about that journey. But we're not just talking about hot flashes and hormones today. We're going to talk about ethics, access, and advocacy with the brilliant Jennifer Lanoff. Thank you so much for joining us today.
Yes, I'm so happy to be here.
Okay, first, your story.
Okay.
Not many lawyers go back to take care of humans. What happened?
Well, it's only funny. Well, it's funny for a lot of reasons, but I have resisted for so many times doing anything lawyerly because, everyone when I went back to school is like, oh, you can be a great med mal lawyer. Oh, you can start, you're going to really know it. And I just have been like, nope, I want to see patients. I want nothing to do with this. But so anyway, okay, let me start from the beginning. So I was a public defender for 25 years-ish, including, sort of during law school, representing the poorest of the poor, hanging out at the jail, working on prison conditions for kids and adults, trying murder cases. During 9/11, I was like the only person trying a case because I was 9 months pregnant and the entire courthouse was empty, but the judge was worried that I would go into labor. So we had to finish our trial. So there were just, it was crazy, but I did it for a long time and it's a lot of fighting with people. And it's also hard work. Although I have to say this is hard work too, but in a different way. It just tugs at your heartstrings. My son is an investigator that now at the Public Defender Service in DC, and he sees it, right? Because there's no happy ending, right? The clients are just as much victims as the victims. So it's a hard job, and it couldn't really figure out what I wanted to do next. And I've always loved reproductive health. So given that I was old, I decided that I would, I interviewed everyone. I said, should I go to med school? Should I do this? Should I do that? And every doctor I talked to said, do not go to med school. It's a waste.
It's long.
I
It's
know.
I mean, no offense to the people who went to med school older, but it is a 20-year-old game for sure.
I agree.
Not just length of years, but it's grueling physically.
Yeah. And I also realized I didn't want to do I don't need to do surgery. So then I thought, oh, I'll become a midwife and I'll just do some very low stress, because GW has this great, or they used to have this great midwifery program. You could deliver in the hospital. If it became complicated, the doctors would come in. And so I thought, this is easy. And so, well, not easy, but then I went to school. I went to Hopkins, drove back and forth to Baltimore every day because I live in DC. And then I just was on that path. And then I did my first rotation when I started Georgetown, the master's program, at a home birth clinic. And I hope I'm not insulting anyone, but I was basically like, oh my God, I don't like pregnant people. First of all,
Way to be honest with yourself, though, ahead of time.
well, it was just funny because my whole path was midwife, and I had been douulaing and I had been doing all this stuff, but I was, measuring bellies every day. And I realized that I always looked forward to the Wednesday, which was the day they only did GYN, because those were the most interesting days. And, of course, at that clinic, I already knew Rachel Rubin. So I had been involved with NAMS. So Rachel's my neighbor. So I have known her forever. And I had already sort of started down this path. So I knew some stuff. And then, of course, they were like, we don't mention the E word in our meetings with our patients, which is estrogen. And so I really spent a lot of time trying to educate that group of clinicians about hormones and all of that. But yeah, then I realized that. And then, so as luck would have it, Jim Simon was willing to take me on as a student or, for a clinical rotation. And so I worked with him for a year and with his amazing PA, Lucy Treen, who is a quiet genius. I mean, she's amazing with all of this stuff. So, and then I fell into it. So, it's hard to say. I think I really wanted to do direct patient care. I didn't want to go work for Planned Parenthood or National Women's Law Center. I wanted to actually help patients. If there's Armageddon, being a lawyer is not that helpful. So I thought, I'm just going to learn, I'm going to learn some skills. So I guess that's my story. There are probably other versions of it that I say, but
it's very unique. I mean, there's some combo MD-JD programs, but they don't really practice law.
Yeah.
Right? The fact that no, that was your career.
Yeah.
And then you pivoted is very unique.
I still sometimes identify myself as Jennifer Lanoff from the Public Defender Service. It's so part of my...
It comes out and you're like, hold on.
Well, yeah. So one of the other things I did when I was a lawyer was I worked for the Board of Professional Responsibility. So we heard a lot of attorney ethics cases. So that always sort of interested me, sort of defining what's ethical. And, the med mal stuff, I always thought about that because I always felt so, I was on the lawyer side. I saw these poor clinicians who had tried to make good judgment decisions and then were getting sued. So I've sort of always been interested in that whole world, but I have put it off until this year when I feel like we have to start talking about it some more.
I think that's the magic of anybody who brings in very disparate pieces of themselves and then they have a superpower that you're like, I didn't go in this to have a unique lens on advocacy, ethics, and like menopause, but you do now
Yeah.
because you have that background and that like deep, deep understanding that if you just went into medicine and went straight into medicine, you wouldn't have that. You don't even have the language really. Like to me, I'm like, Jen, can you define ethics for us? Like it sounds stupid, but like we better start there.
Yeah, well, it's interesting because when we all take ethics, I mean, I took it in school, you took it in school. I think it was all the course we hated the most. I don't think that any of us, professional responsibility, it was sort of like, let's get through this. Maybe it's a light class. I feel the same way when I gave a lecture at ISWISH this year. I was looking over the schedule, and every time I would see my own lecture, I'd be like, oh, that's boring. I'm skipping that. And then I'd be like, oh, that's what I'm doing. It's not the most exciting or sexy part of it, but I think it is really interesting. I guess when I first started thinking of it, when we started, ethics. Okay, so historically, right, it used to be autonomy, justice, beneficence, and I think it was really coded in a way that we were not supposed to harm our patients. In the same way we think of medical malpractice, right? We shouldn't be doing things that will hurt them. And I think that's sort of the way we've always thought about it, right? Don't give them medicines that are unsafe. Don't give them treatments that you have terrible side effects. But I think given our political world, and it's maybe even not the political world, it's just the world we live in right now, because it's clinical and political. But, we are starting to deny patients. And so I think what it first sparked me was so I think we have a new definition of ethics. I really think it needs to be changed. It has to be, do no harm has to be also the harm of doing nothing. Because I think it was always a very active way of talking about harm, right? Doing something to hurt your patient. Now I think we have to really consider and take a long, deep breath and look at how harmful it is to not do anything, right? I mean, you think of abortion, right? You think of the woman in Georgia with she's, brain dead and being forced to carry the fetus. You think of young children who are incest survivors. I mean, and you think of gender affirming care, right? So, I mean, this is not doing that, not treating those patients with what they need, and at least engaging in shared decision making. I think it's sort of the new ethical world. I think we have to really focus. And, of course, this we can talk, we're talking about this, but like goes through menopause, which feels like a little crazy, but I think it's true there as well. But yeah, I think the ethics, I think we need to have a new framework for how we view ethics.
Medically, legally, correct me if I'm wrong. A clinician is much more likely to get sued for doing something and having a side effect or a consequence of it than be sued for not doing something, with the exception of failure to diagnose.
I think that's probably right. I think that's probably right. Although, I do think we're in this new world. We don't know. Can people who have been denied gender affirming care start to sue when they're not allowed to make their own autonomous decisions? If I were a lawyer, I mean, actually, I'm a lawyer, but you know what I mean? Like, that's not a crazy lawsuit.
Not many people are allowed to be like, hold on, yeah, I am a lawyer.
Yeah, well, I'm not doing that, but you know what I mean? Like, I don't think that's right? I mean, what happens if a kid commits suicide because they're not allowed to take gender affirming hormones? Why can the parents not sue?
I mean, it's so hard though that child might have died by suicide regardless.
Of course.
So it's like, to say a lack of action caused something in the future, that's incredibly hard to stand behind.
100%.
But to switch to, I think where many people are starting to talk, whether or not it's going to materialize, is, can we sue? Can there be a class action something against the WHI?
Yeah, that's funny.
And more against like the media, right? Like who actually did the harm in the WHI? And do we have a big enough case to prove correlation equaled causation?
I mean, it is so interesting, right? When we went, I don't know if you want to talk about it now, but one of the things when I gave a lecture that was similar to what we're talking about a couple weeks ago. And, when I first started thinking about harm in menopause, it sounded kind of silly because I was like, of course, abortion's harm, not giving birth control's harm, not giving, gender affirming therapy, all of the things, that's harm. But like, is not giving someone some estrogen harm? But
is giving somebody estrogen gender affirming care?
Well, that's funny.
I mean, that's like, to me, I had this amazing post by a personal trainer on Instagram, and they were like, bros at the gym doping testosterone to get the look that they want to get is gender affirming care. Isn't all of this gender affirming care?
I mean, I think so.
Maybe we've politicized that, but it's like, it's actually all humans need gender affirming care.
Yeah, I mean, I don't know about you, but I have to do prior authorizations every day. It's a little strange for progesterone for my patients who want it, not even estrogen, but I have to sort of like say it's not being used for gender affirming care. But also I'm like, why am I even saying this? Why, it's just such a strange exercise that the insurance companies will only give it if we say it's not being used for gender affirming care. But I
And on
also,
the flip side, insurance companies will only pay for testosterone if it is for gender affirming
yeah,
care.
that's so interesting. Right.
Right?
Exactly.
So, like, that's the double-edged sword of it is like, when can we just call all of this gender affirming care to get rid of all this insurance bullshit?
I know I do wonder that, like, our patients coming in and just want some testosterone, they're saying they're transitioning. I don't know. They could, a patient could show up and say anything, right? They could say, I'm having hot flashes 100 hours a day. And you'd be like, okay.
But I mean, I think that's the slippery slope of all of this is the erosion of trust in the medical system because people are lying to get the care that they need, whether they're lying to the pharmacist or they're lying to the insurance company or they're lying to the doctor and nurse practitioner. It's like the erosion because we don't treat people as the individuals who have valid concerns, who have valid requests, and they have to do all these loopholes.
Yeah. Yeah, and it's just all about it's nothing more complicated than shared decision making, right? I
Yes.
just think that is the and consent, like informed consent, not just
Let's
like
define can we define those things for people?
yes. I mean, I think, and I think there are not that many people, I think I overwhelm my patients sometimes with studies because I'm always like, I promise this is true. Let me send you my Google Drive because I, maybe just don't have enough self confidence that they'll actually believe me. But I mean, they love it. I mean, of course, we have to have an appointment to discuss all of it. But I say to like, here is the evidence. Or, for breast cancer, I am sure we're going to talk about this. So I don't know if you want to talk about it now, but that's the ultimate situation where I think, and this is what bothers me the most, where someone will just say, an oncologist will say no to a patient. And like, there is nothing more that drives me crazy than when someone just says no to a patient because and this is the whole sort of the regret theme, which I talked a little bit about. I think a lot of the time we don't do things is because we're worried that someone might regret it, right? Gender affirming care, I think we make these decisions. What, they're 16. What if they regret it someday? But is that our choice to make if the patient is advised of all the consequences and what this means and gives their consent? So I think consent is a deeper conversation. It's not just someone signing is talking to them about the side effects, talking about the pluses, talking about the minuses. I mean, taking the time to really explain to patients what the evidence is. And by the way, if there's no evidence, which there are a lot of situations like that, then saying like, we don't know, there hasn't been enough. And for our breast cancer patients, as Corinne Menn says all the time, like we can't wait for a randomized controlled trial. These women are really suffering, and but if a patient understands that and knows that, and then reads the habits trial and reads the data then I feel like we get to decide together what they think is best. And I think people, even if they decide in the end not to do it, I think people feel so empowered by the fact that A, you are listening to what they are saying and not just saying no to them. And B, that you are like offering them some hope that maybe their symptoms can be addressed. So, I mean, I don't know. Consent is much more than just signing a piece of paper. I think we are all quick to do it. I'm a lawyer. I know more than anyone. I just signed the thing. But I think when it comes to really important decisions, we should be really sitting down with our patients and going through it. And when we're done with conversations, we throw all this stuff at our patients and a meeting with them. And then we say, okay, any questions? I think we got to say, what are your questions? It's as simple as that. Like, what are your questions? Because they're overwhelmed.
Yeah, I mean, I think I'm gonna make this a question more than me what I think. What percentage of the degradation of the ability to listen, the ability to answer questions, the ability to have a true informed consent is because of the 10 to 15-minute patient visit that is the current medical system? Because to me, I'm like, listen, people who go into healthcare, they've got big hearts, they're smart people, otherwise they wouldn't be accepted into the schools. They don't lack a moral failing. Right? To me, they're usually in it for the best of the patient. What eroded it? And to me, I'm like, it's not the people in the system, it's the system.
Yeah, it's the time, right?
It's the time constraints in the system. And, when people are like, what should you ask your doctor so you can learn in the doctor's office? I'm like, you can't learn diddly squat in the doctor's office anymore. In addition, information besides what's behind paywalls, which I think is unethical in the first place, that's your tax dollars going to research that then gets locked behind something you
Maybe
don't have
not.
access to. What's that?
or maybe not anymore given what's going on in the country.
Right, yeah, or lack of research, but, is the ability for the average person to truly get a lot of knowledge now, right? And I see that as, like, it's a different conversation. The doctor doesn't know it all. They don't know all the studies. They've been figuring out diabetes, heart disease, sleep apnea, and, like, osteoarthritis while 20 years after the WHI's been going on, they didn't learn about hormones, right? And a lot of women know more than their practitioners now. And so I'm like, it's the
But where are they getting educated? No, I love that. I think patients are really grateful when you say, you know what? I have no idea. Like, let's talk about it. Let's do the work. Let's do the research and let's figure it out if it's right for you. Instead of just, echoing parroting what they learned 20 years ago. I mean, if I walked into a courtroom and I said, "Oh, here's my case from 2001. It's binding. That's it." I mean, people would think I was ridiculous. So I think, and our patients are smart and they're really trying to educate themselves. And it's so important to make sure that we are leading, pointing them in the right direction for what they should be reading and learning about.
Yeah, I mean, part of what happens behind closed doors that you and I know about is, like, some physicians are I don't wanna put the words into their mouth, but I would say feeling threatened or annoyed by patients coming in, being educated, advocating, because now people like us are like, "This is how you talk to doctors. This is how you ask for trial of medication. These are the papers you need to know." Like, we are getting the information out there, and then the backlash from and not all healthcare providers, but, I was having this conversation with somebody else. They were shocked that a doctor was, like, annoyed and upset that women are coming in asking for stuff. And it's like, yeah, we're giving them more burden, right? Like, they're already completely overwhelmed with their day and their job, and now it's like people are coming in wanting to talk and wanting to discuss and, like, wanting to advocate, and it's like, I'm sorry. Like, I'm sorry, not sorry. But it's the system, not the people in the system. I'll die on that sword.
Yeah, and when I always say to my patients, like, this is not me, it's not you. Your insurance company has given me 15 minutes. So I'm going to do my best to say what I need to say. I'm going to give you some reading to do, and then maybe we come back and talk about it. But yeah, and I agree, it's so much. And then again, there's so much information now on social media. How do people even know where to go? And patients like, I looked on Reddit, and I'm like, Reddit is not a reliable source. So we have to really be careful to point them to the right things.
But it's a tough question. I mean, I'm happy to take tips, but it's tough because it's like, why is AI still wrong about vaginal estrogen? The Cleveland Clinic website's wrong. The Mayo Clinic website's wrong. Like, the big healthcare places data is wrong on their websites
Sure.
about hormones causing cancer, or you can't use vaginal estrogen because it'll cause a stroke, like all these wrong things. So I'm like, now AI is wrong because the big reputable websites are wrong. And then here we are being like, watch out where you get your information from. Like, it's a big tricky thing.
So tricky. And yeah, I mean, it's the whole social media world is crazy. And, you know, yeah, I don't know. It's hard.
Yeah, I mean, to me, it's like, and I get it, I sympathize because it's like sometimes you just want a quick answer to something, right? And like, most things in healthcare are not a quick answer, and really, it is, dude. Your body's one of a kind, my friend, right? Like,
Yeah.
we're not Toyotas,
I know
but
what I'm about to say. Sorry, go ahead.
yeah, no, I was just gonna say, like, it's if you start seeing themes trickle up on social media, and like themes of like, okay, are doctors saying this? What are they saying? And I think the other thing, just for the layperson to understand, is like, we don't have it all figured out. We will never have it figured out. Had we always had it figured out, we would have like started by washing hands instead of having to discover that. The earth would still be flat. Like, we'd still be using leeches. Like, the practice of medicine is never static. It's never static. And that's a tough pill to swallow for a lot of people who just want the answer, to be like, dude, we could figure out 10 years from now that we should have been giving 10 times the estrogen levels.
Yeah.
We got no idea right now.
Right. And
Right.
well, the problem right now is research. I mean, I live in DC, like research, people are being fired. I mean, NIH has been decimated. So all these, and even more than that, these people are taking early retirement. So even if we try to recreate it, those people are gone.
Well, plus it's like trust, and people want stable jobs,
Yeah. Right.
and it's like, if they're going to leave and not come back, because
Yeah.
they've gone somewhere
Why
else.
would they? It's interesting that you said the thing about the Cleveland Clinic because look at what, Hallie Peterson just did in that menopause note. I mean, right? This is someone who has dedicated her life to breast cancer treatment. And she is now out there saying, like, we have to talk about with our patients because it may not be as dangerous as we think. And it is all about shared decision making. And are our patients, I think oncologists and everyone just look at it that no breast cancer, no breast cancer, no breast cancer. Are they more likely to die of a broken hip when they're 80 and never come out of the hospital, right? Like, is their marriage ruined because they can't have sex because they, are sweating? Like, there are just so many different things that cardiovascular health, right? Like, we know all these things. And that's why I feel like it's harmful. It's because we're not addressing all the other things. And then we make people afraid.
But you have to look at the goalposts. The goalpost for cancer care is cure. What do the frickin' signs on the side of the highway for MD Anderson say? It's cure. It's cure. It's cure. And that's what you go to them for. You go to them for cure, right? And the good news is a lot of this is very curable. That's the thing that one of the things that annoys me about the breast cancer thing is like, you guys, by and large, 95% survivable now. That's not how it was 20 years ago.
No.
Incredibly survivable now. So the goalpost has to change. It's like we won that game for most people. Now they need to live and not just be like, let's keep you cured. We don't know, so let's keep you cured. Is like, move the goalpost until oncology cares more or equal to something else besides just cure rate. You're not going to see that coming from. That's their goalpost.
There are two things I always show my patients. They are blown away by. One is something I put on Instagram all the time because I just need to be able to see it, is the rates of what people actually die from. Osteoporosis up here, breaking your hip, mortality, huge when you're 80. Cardiovascular disease, and then breast cancer. Breast cancer's all the way down here. And so I want to talk to them about that. Then, then there's another thing I say to them, which they can never believe, is that actually hot flashes are not good for you. I think people feel like they really have to get through these hot flashes because there's no other thing that we actually have to get through, right? We can't see, we wear glasses. We can't walk on hot ground, we wear shoes. And it's just funny how people have these attitudes. But once I start talking to them, like, it leads to later life dementia. If you're waking up 100 times at night because of a hot flash, you're going to have increased risk for cardiovascular disease. And I think that is the harm, right? That when we are not giving our patients the information that they actually may be hurting themselves by not doing this. It's more than just breast cancer. It actually is brain health, it's bone health, it's, cardiovascular disease prevention. I mean, we are not using them for prevention, but they should know what the rules are in terms of what the numbers are incredible.
Yeah, I was like, for like one hot minute, I thought I had like invented something new. And I was like, it's called the doctor-patient relationship. Because I'm like, I want to create a clinic where I have like an hour with somebody and we just talk and I just hear them tell me what they're worried about and how I want to see how women are processing this. Right? Because I want to see what they think is important and have they considered these other things and blah, 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 blah. And I'm like, yeah, I want a relationship with them. Thinking this was like this novel thing because it didn't exist in my insurance-based medical practice, right? And I'm like, oh, wait, that was like how this all started. Was like a relationship with a doctor. And it like is completely gone. And that's why, so many people, they're like, the doctor only cares about keeping me alive. The doctor only cares about curing the breast cancer. The doctor, blah, 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 blah. And it's like, well, yeah, when you have 10 minutes, you've got to have one goalpost.
Yeah. Yeah,
You
absolutely.
can't have, but I was like super humbled by my like discovery. I'm like, you know what I want? I want a relationship. Oh, I think that's called the doctor-patient relationship, which was like a thing.
Yeah, that used to be a thing. I don't know.
That used to be a thing. Let's go back just so people know. The Menopause Society puts out menopause pearls. And the big thing that came out recently was that a breast oncologist wrote the pearls, and that's meaningful. It wasn't not an oncologist.
She's breast cancer surgeon and oncologist, but like the head of breast cancer surgery at Cleveland Clinic.
Yeah. And so that's powerful in and of itself. Basically saying we need to rethink this absolute no on breast cancer survivors and hormones.
It's huge.
It's super huge.
Because
the other thing that like totally annoys me about the breast cancer hormone thing, this is my other pet peeve, is people are like, doctor said I can't have hormones or I can't have estrogen. And I'm like, well, you can have vaginal estrogen, progesterone, testosterone. Like none of that's ever been written off.
I know.
It's like
people like, we're not taking your ovaries out when you get breast cancer. and you're still getting estrogen. So that, that doesn't seem to be a problem. Or like, you're getting pregnant. But yeah, no, I know. I love that.
That's the thing is like young breast cancer survivors, just again, I like to explain it to people, young breast cancer survivors are allowed to get pregnant. Allowed, air quotes, right? Like they're like, this copulation may proceed, right? Like they're in your bedroom. But
Right.
like, they did, and they studied that. And they were like, let's let these people get pregnant. Let's see if their breast cancer comes back. Keep in mind, your estradiol level when pregnant is 2,000, right? Where we bring it with postmenopausal hormones is usually around 50 to 100. So they're allowed to get pregnant, and then they're allowed to have an estradiol of 2,000, but then they're not allowed to have postmenopausal estradiol that's going to put them to like 50.
It was like 20. Yeah, I mean, the same is true of migraines now too. I feel like so many of my patients come in and they say, "Well, I can't have any estrogen because of migraine. I have a migraine." And I say, first of all, like, do you actually have migraines? Do you know what a migraine is? Like, has anyone ever defined that for you? Do they just see it in your chart? You said it, and now you can't have, estrogen. But also, like, go do the reading. Like, Palin Bator is doing some incredible work about how safe estrogen, even birth control pills, are when it comes to migraines. And so, like, bring that to your, we should be doing this research. Patients shouldn't have to be doing this themselves, right? People should be, who are giving birth control pills or contraceptive prevention, should be looking at this stuff every day so that they know. And, I don't know. I find it very frustrating. The no makes me crazy.
Let's talk about informed consent. Informed consent is a big thing in medicine. It basically says, and you have to sign papers before surgery, before you get treated. It says informed consent, blah, blah, blah. But a lot of medical malpractice hinges around, was there a breach in informed consent? So I think it's important. But a true informed consent is, I understand the risks. I understand the benefits. I understand what might happen if I don't choose this intervention. I don't think that can happen in 10 minutes.
No, I agree. Yeah, I agree. It's very hard to make people understand, but I think, it's, if we start breaking it down, because sometimes we get in these very clinical modes and talk about the data and the numbers and the risk reduction. I think if we really break it down a little bit better for our patients, they will understand a bit better. Like, if you say 50% reduction, but it just, reduces it one, the way we say numbers now can be really meaningless to people, in terms of tamoxifen and aromatase inhibitors, right? When patients are suffering with the AIs, and then we're like, well, taking the tamoxifen it's only going to decrease your survival rate by like 1%. And, no one knows that. They just listen to what their person says, but no one sort of talked to them about all the other alternatives and what that means. But yeah, I mean, right. It's all about, our patients are smart.
I think my big recent bugaboo on informed consent is antidepressants.
I know.
Because what's that?
The bone study. Yeah, you are
Yeah.
very obsessed with it. It's good.
Well, because number one, the risk of bone fracture on antidepressants, nobody knows about that.
I know.
The risk of not being able to come off the damn things ever, or a very slow wean. The risk, if nobody's told that, like, hey, if I start you on this, you might never be able to come off of this again. That should be something you think about, right? And then number two, if we do try to get you off of it, there's withdrawal symptoms, there's issues. And then number three is the rate of sexual side effects, which is like upwards of 80%. That's not zero. Most people aren't told about that. And then they're like, I have low libido. I have blah, 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 blah. And it's like, well, how long have you been on this SSRI? 20 years. And I'm like, did you have a plan to ever want to try to get off of that? Like antidepressants are like so under informed consent in my world. And I get it. The person in front of you is suffering. I get it. But those medications are not benign. They're not zero risk.
No, of course not. Tamoxifen, right? Endometrial cancer risk, blood clots, stroke. I mean, that's dangerous too, but I don't think anyone ever really knows that, right? Chemotherapy can cause all kinds of damage, radiation, immunosuppressants. I mean, we don't really talk about all those things with our patients. For some reason, the hormone therapy is the one where we're like, the risks outweigh the benefits.
Isn't that wild?
I really spend so much time trying to figure out why.
The other really weird thing about hormones is this like insistence on them being natural, but no, like by definition, no other medications you take are natural.
I know. That makes me crazy too.
It's very weird.
Yeah. Yeah. I feel like we should talk about social media. What do you think?
Yeah, let's do it.
I don't know. I feel like it's really important.
You're like, I don't know. Social media just seems to be everywhere. We should probably talk about it.
Well, I just feel like there are a lot of ethical issues that none of us have really thought about when it comes to it. I mean, people are DMing us with questions. People are really uncertain about what state laws apply to them if they're in one state and you're in another one. I think people are people are unprofessional in terms of like how they attack other clinicians on social media, and they undermine people's relationships with their own clinicians. This is a whole world of ethics I think we all need to be talking about, because social media is here to stay, and we have to navigate it both as clinicians and as patients and try to figure out what
Yeah.
that, but it's hard.
It's super hard. And just the way that social media is built. I mean, if anybody's read Nexus, the book Nexus, it is frightening,
Yeah.
right? Like big time frightening about how social media is built to put forward inflammatory things.
The clickbait.
Clickbait, yeah. But what's very interesting to me on social media is the amount of people who DM me for my opinion on something they're on, which like I get the fact that like I'm a hormone expert and I say that I am, like that's not weird. But what's weird to me is ask the person who prescribed it with you. Like that's what's fascinating to me is like you have that relationship already, you have the product already. Ask that person this question, not a stranger who doesn't know your history.
Yeah, but maybe they don't have I mean,
But that's what social media does. It creates a familiarity, it creates a closeness, it creates a like people have spent so much more time listening to me than their clinician,
yeah.
right? Like especially podcasts, like they're very intimate, right? And so it's like but to me I'm like it's very interesting that I'm like ask the person who prescribed you. And if you don't ask that person, what are the reasons why?
Yeah, exactly. And you have to choose who to trust. And then, we all have to be careful if someone really does want to have us be their clinician. Do we have licenses at the place? How is it, so confusing for everyone with telehealth? And
People don't know that telehealth relies on state licensing. Like people just like they want a remote phone call. And
yeah,
it's like, dude, the telehealth companies that invest the money in being able to see all 50 states, people don't understand that's thousands and thousands and thousands of dollars to state licensing committees.
yeah,
And to me, I'm like, I got 7 million people in Washington state. Like, I'm not getting another state license. Another state does not need my money. I've got people.
yeah. And what about all the EHRs and like these period apps and all, where people are saying when they're having their cycles? I mean, I worry so, all of our patients are saying, don't put this in my chart, or what are you saying in my chart, or how can this be used against me? That's a whole other minefield, right? We have to be so careful who even knows who has access to these things. So that's, do you show your patients this? Do they get the results early? Like there's a lot of information out there that our patients don't want to be shared to the public, but who knows? And so gosh, all of it, it's
Well, even like it's all the de-identified data that the EHRs sell.
yeah,
That like that's happening. Nobody's talking about that. I mean, I'm wearing a Whoop band. I freaking love it. And you can log on there because it'll tell you what's eating late at night is not great for my sleep. Turns out.
shocking.
Guess I needed an app to tell me that. But like you can log when you have sex. And I'm like, well, that might be interesting to see if an orgasm helps you sleep better. But hell if I'm putting that on the internet, right? It's like
Yeah,
I don't think you should even have your phone in the room when you're having sex.
no,
Probably
that's
not. You know, like they did a study where like not a small majority of people check their phone while having sex.
come on.
I know.
That's some bad sex.
No, it's crazy. It's like 20%, or I don't quote me, but it's not zero.
Yeah, that's crazy.
Yeah, it's crazy. It's like take your phones out of the bedroom when you're doing all things. But yeah, like the apps will be like when you're having your period, when are you doing PMS, when you blah blah blah, and it's like that's a lot of super data that you actually. I mean, the Instagram, it's free for us to access. But it's like on these other apps, like you're paying for the privilege of giving them all of your intimate knowledge.
I know. And they're medicines, they're your medicine charts, right? Someone sees you're doing Lupron for endo, but you also can do Lupron for, to block when you're younger and want to block your hormones. So like, everyone knows what you're doing, and all of it can be suspect if, it's not understood in the right context. So so much of our information is out there, and just need to be careful in this, political arena. It's a little scary.
Yeah, totally. Let's talk about the. I want just in case people missed it, but you gave an amazing talk to like there's a group of menopause providers. They meet on Mondays. It's a great gathering of minds, and you basically gave a talk of not treating menopause with hormone therapy can be construed as doing harm. with the overwhelming data that we have, that the risk of osteoporosis, the risk of heart disease, I would argue the risk of depression, I would argue the risk of disordered sleeping, I would argue the risk of diabetes. The data is so profound. And this is like, this is the book that's coming out that I wrote that's coming out in September, is like the data at this point is so overwhelming that hormones are preventative medicine.
100%. I mean, I say this a lot. I need to find my statistics, and I'm sure you have them all over the place. But I mean, what medicine would come out for a man, right? Reduces osteoporosis by up to 37%, lower diabetes by 30%, cut coronary heart disease risk 50%, 50, but yeah,
Colon cancer,
yeah, colon cancer, lung cancer, LDL
Parkinson's,
decreases, blood pressure decreases.
frozen shoulder.
I mean, triglyceride, it's pretty unbelievable. I mean, I think the cardiovascular disease is a little bit of a no-brainer in my view. There's some great stuff from John Stevenson, who gave some really good lectures at the International Menopause Society conference about how this should absolutely be used for cardiovascular disease prevention. I think the data is still a little bit out with dementia. I think that's a little bit of a harder one.
We're
But
never, it's like Dr.
yeah,
Corinne said with breast cancer.
yeah.
If you're going to hold your breath for the day you get diagnosed with dementia, it's been going on in your body for 20 years.
Well,
Right.
same with breast cancer. It's been 7 years, right?
Yeah, exactly. So to me, I'm like, you need a 20+ year study with a placebo controlled
What's
proving
gonna
that is not going to happen. And I think people who are going to die on that sword, they're like, we don't have a placebo controlled trial showing decreased risk of dementia. And I'm like, that's right. We don't. It's a deadly disease with no cure. The medicines we have are crap with significant side effects. Why wouldn't you do everything you can if you have pretty good data that it's not going to cause harm? I
That's what
think
that
that's my bubble with hormones and dementia. Like when you shorten that and you're like, hormones prevent dementia, that's when people will poke holes.
yeah.
But if you build that argument properly, I think it stands.
But I mean, I think, Pauline Mackey and Rebecca Thurston, two of our, they're incredible. They say things like, when you're waking up at night with night sweats 100 times, there is no question that leads, you are laying down more white matter hyperintensities in your brain, and that leads to later life dementia. Now, of course, this link hasn't been made. If we stop those night sweats, will you be less likely to develop dementia? But I mean, that evidence is not not controversial at all. This is what happens. They put these little things on people, and they see what happens to them when they're having night sweats they might not even realize. So I mean, that is just a no-brainer to me. And yeah, I it is really interesting. I mean, I think at worst when it comes to dementia, neutral, but the bone stuff is pretty amazing. I mean, estrogen is used to treat osteoporosis in Europe. I am so aggressive about making my patients, or at least trying to convince them, to start some estrogen in their mid-50s. And I'd really love to do DEXAs, because why are we not preventing osteoporosis? I mean, it's a deadly disease. I mean, it really is.
Deadly, and expensive, right? Like, if death doesn't matter because death actually saves Medicare dollars, let's argue that. The rehab, the hip fracture, the ortho bill, the hospitalization costs Medicare money. And now, I mean, look at Rachel Rubin's data with vaginal estrogen saving Medicare approximately 6 to 13 billion a year just in decreased urinary tract infection costs.
I know, it saves lives. I love it. I mean, it's true. I'm literally going to my mom. My mom's in assisted living, and I was like, when we were doing our interview, I said to the guy, who was like I was like, okay, we are putting everyone on some vaginal estrogen, all these 80-year-olds. And he was like, please do not talk to me about vaginas. But I'm like, this is serious. We can prevent a lot of problems by just getting all these 80-year-olds on some vaginal estrogen. Easy.
And it's fun to be the thought leaders and be at the forward, because like you actually do see the culture changing of it, right? It's like, how quickly have we gone from fear to prevention? And prevention's a big high stick in American medicine.
Yeah.
Like we don't tell everybody to take baby aspirin. We don't tell everybody to take a statin. Like, prevention's a big stick. And I don't think we're going to say all American females should take hormones. I don't think we're going to do it. But I think for the people who want to do it, they should be allowed to do it. Again, because harm is minimal and gain is large.
And that's what Okay, great. But we just need to share that with patients, right? Like, I'm not even saying we have to persuade them to do it or put everyone on it. I just think people need to know the data and see that osteoporosis is a risk. So if they have low bone density, they'll realize the risk of whatever estrogen risks are, the benefits are far outweigh when it comes to the bone health. Like, I just think people need to be able to make those decisions in an informed way. And I just don't think we're doing it because we somehow think it's not good for you. I think it's really harmful. It's so interesting to me because as I said when we started, like I always thought of harm as doing something to hurt a patient. It's like a tort in law school. But I think it's flipped now. I really do think we have to view it from different, like all these sort of old guard, clinicians who are saying, well, we don't have the evidence, but they don't think they're harming, but that is harm. And so they can't stand behind, first do no harm, because the harm of doing nothing is even more harmful sometimes.
Yeah, it makes me think about the studies we have looking at decreased incidence of breast cancer in women who are on testosterone pellets. And there's a couple of studies. There's like a 3-year study and there's a 5-year study comparing it with National SEER database incidence of breast cancer. And off the top of my head, it's looking like in these studies, testosterone decreases the risk of breast cancer by about 30%. Might be a little bit higher, not 2%. Right? It's like if there was a drug that decreased, especially a woman at risk, her breast cancer risk by 10%, she would be on it. Insurance would cover it. There'd be a Super Bowl ad. Right. And so to me, this is the tying back to ethics and harm. Is it unethical to not be researching that further? Because I'm like, we've got prelim studies. Where's the study? Like, what do women and clinicians fear more than breast cancer? ALS, maybe,
Yeah.
but not much.
It's pretty, and I know that's pretty crazy. Yeah, but I mean, that makes sense, right? In the Women's Health Initiative, the conjugated equine estrogen, when women were that alone, it decreased their risk of breast cancer. So testosterone aromatases into estrogen, and it all makes perfect sense. But you're right, we have to share that. We can't just wait for there to be randomized controlled trials because they're never going to happen, and then all of our patients are not going to be alive anymore.
Well, I mean, and that's the thing is people are like, there needs to be trials. And it's like with generic medications that aren't patentable, you need to understand that there will not be trials on these things.
There's not enough money. Pharmaceutical companies don't care. Especially things, the drugs that are cheap. One thing, if testosterone's cheap, they're not going to spend a lot of
Super
money.
cheap.
Yeah, they're not going to spend a lot.
I mean, it's super interesting because it's like, what can they patent? They can patent a synthetic androgen receptor modulator. Guess what they're making for the treatment of breast cancer to research? Selective androgen receptor modulators.
Yeah,
Right? You're like, once you know too much, you're like, oh my God, you can't make this up.
I know.
That
But the
like the
FDA,
low hanging fruit is right in front of us and it gets dismissed, it gets fear mongered, it gets withheld, it gets gatekeeped. You can't have this unless you're transitioning. Like women can't access the cheap, safe, generic stuff.
it's insane. And right, and pharmacies are refusing sometimes. Yeah, that I can't get over. The pharmacists saying they're not going to give people miso when they're having an IUD, and they have stenotic service because they think it's an abortion drug, right? Like the overreaching in the pharmacies and not giving people these meds is pretty crazy.
Yeah, the pharmacy, I mean, I have a lot of pharmacists now who listen. Thank you for listening. And who follow. Thank you for following. And again, it's like going back to social media and how do you behave on social media? It's like they're 90-second reels, my friend. Like the podcasts are for nuance, Instagram is not. But there are pharmacists they're truly trying, but they are regulated by their bylaws. I don't call them laws, but bylaws, as best as I understand it, that they do have to put any hormone in a biohazard bag because it can be teratogenic and it can cause cancer. Like, in all fairness, if you give people synthetic high doses of estrogen, you can cause uterine cancer, right? That means we have to put a cancer warning label on all types of estrogen, no matter what the dose, no matter if it's bioidentical. Pharmacists need hoods for packaged hormones. Talk about increased cost.
Yeah, that's crazy.
But it's like those things, I can't advocate for that. I can't advocate, like the pharmacists have to change their bylaws so they're literally handing women their bioidentical hormones in biohazard bags with inaccurate boxed warnings on them.
The box.
Like
Yeah, the
it's,
box warnings.
it's insane.
Yeah. I mean, yeah, there are ethical minefields everywhere we go. I mean, the landscape is just, especially with the politics and HIPAA and what we're allowed to protect and now, and whether, all these things that the rights that we're going to lose. I mean, I'm worried about
Do you
birth.
think HIPAA is going to go away? Have you seen talk of HIPAA going away?
I wouldn't be surprised that there will be exceptions. I mean, I think it's all about pregnancy terminations. So I wouldn't be surprised if there were, who knows, exceptions made, right? Or exceptions made for certain situations where they, if someone has a miscarriage and you're allowed to look and see what they're, I wouldn't be at this point, Kelly, nothing surprises me anymore. I never thought we would be here, right? I never thought I would be saying like, you need to get your 16-year-old an IUD because I don't even know what's going to happen to birth control. So, I mean, I'm, and who even knows if Paragard will be around anymore because it's only, at least you can say with the Mirena and the levonorgestrel IUDs that they're also bleeding control. Like the Paragard, it's only birth control, right? And conceivably it's, is you could take it right after you get it inserted right after you get pregnant and it can be emergency contraception. That's terrifying too, right? So I don't know. Yeah, we could talk about this.
So
There's so much to talk.
everybody needs a good doctor-patient relationship. Everybody needs a good lawyer on speed dial. But I mean, I want to close it out not by scaring people, but to be like, hang on to the precious clinicians that you have who are in your corner, who do advocate for you. Hang on to them or find them. They're out there.
Yeah.
But at the end of the day, I do fully understand, like, not everybody has access to that. And especially people, with state insurance. I was talking to a doctor the other day. They see 50 people in a day. How is that not unethical?
Yeah, that's insane. I don't know how they do that. Those poor clinicians. Yeah, it's like being a public defender and representing 100 people at a time. It's impossible. Yeah, I mean, documentation, right? Making sure that as clinicians, we are really careful about remembering that our notes can be on the front page of the Washington Post, remembering that, our clients' personal information is now on an electric system and could be seen anywhere. I think we all just need to be very mindful of the public nature of these electronic records and then remembering what we're saying in our, the way we say things and the way we document them. For clinicians, that's very important. Not legal advice, of course, but, I think
If I was a lawyer,
if I was a lawyer, yeah, I just, I think that's what it all comes down to.
how do you, I mean, I was like, the question was going to be like, is your lawyer brain in there when you're like crafting, a note to somebody? I'm like, how could it not be? We were doing it for 20 years.
Because in the end, I feel like, for example, we talk about this a lot, like hormone therapy with someone history of a blood clot. Right. And we know the transdermal estrogens are safe. We know there's not a drop of evidence that that's going to increase people's risk of blood clots, right? The transdermals are very safe, factor V Leiden, whatever. And, I send these letters, we write these letters to these hematologists. And I think, I have been able to persuade them that it's safe because they have enough to like CYA. You know what I mean? Like they can say, look, when I make, because that's what, right? It's that regret and that fear, right? They have enough to say, this is what the data said. So my patient wanted this. We talked about the evidence and this, I want to just give them enough information so that they feel comfortable that that's what the evidence says. And even if they say, I'm not going to do it, it's okay to the patient if, it's okay if you do it because I think these are persuasive. So yes, I do. I feel like every time I write one of those letters, I'm just CYAing it. Like, I just want people to have enough cushion that they don't feel scared either about us doing it or even about them doing it.
Yeah. I mean, it makes me think about hormones as preventative medicine when you have United States Preventative Services Task Force saying don't do it. Now, granted, their data is flawed. It's based upon the WHI, right? So it's like that's a flaw, but not everybody knows how weighted their meta-analysis is, right? So it's like
Yeah.
it gets into the point of like at the beginning of our conversation. It's like the patient's informed. That's what they want to do. Even if guidelines don't support it, you want a supportive clinician, but the clinician at the end of the day is always thinking about getting sued in the
Yeah.
United States of America.
But what if
There's never two people in that doctor's visit.
And what if you said, so say an oncologist said, okay, I don't feel comfortable with doing this. Let me refer, or any person, let me refer you to someone I know who has talked about this a lot and who knows a lot about this, right? Instead of just saying no, saying, yeah, I don't feel comfortable, right? I don't know the answers. I haven't done enough research, but here's Kelly Casperson and move to Seattle and then maybe she'll see you. You know what I mean? Like, I think that's almost 50% of it, right? Admitting that you don't know something and then referring, right? Like that's also,
That's wonderful.
right?
Yeah.
Instead of just saying no.
Yeah. I think that's a good answer, and I think what you're saying is, I mean, how many times do you hear it on social media? A woman says, "My doctor said no," and it's a red light stop sign, no questions asked. It's just a no, and they don't give her any other avenue, or they don't be like, no to oral estrogen, but yes to vaginal estrogen. No to estrogen, but yes to progesterone and testosterone. Right? Like it's but whenever I'm on stage and people are like, my doctor said no to blah blah blah, I'm always like, it's never no. There's always something more than
Maybe you
just
guys
no.
can come to a no together, right? You can decide, let's talk about it. Let's see if it's worth the risk. But just saying no is patronizing the right word? I don't want to mean to sort of
It's
lead people.
dismissive.
It's dismissive, right? It's like someone's making a decision for you about it's you. This is you, your body, and yourself. And so, if your quality of life is such that you think it is worth it to take some hormone therapy, then you should be allowed to at least talk about it or find someone who will talk to you about it.
Yeah, I found out in like the actual amazing privilege we have in America that you can get a second, a third, and a fourth opinion. In British Columbia, at least, the physician you have is the physician you have. You can't go get another one for an opinion.
Oh my goodness.
Yeah,
Wow,
you're locked into what that person knows.
that's crazy.
So the good gift in America is like what is as onerous as it is to get a second opinion, it's a privilege to be able to be like, let's go see what somebody else thinks about this.
We also have to be really careful because I feel like a lot of times we undermine each other, right? If I give someone hormone therapy who has a family history of breast cancer and then they go to their oncologist and the oncologist is like, oh my God, is she crazy? Like, what is she doing? You have to stop that right now. I think we all need to be a little bit respectful of each other. And, instead of saying, oh my God, get off that right now, reach out to us and say, like, explain this to me. What's your data? Why are you doing this? That's the undermining of other people that also is a problem because then these poor patients, they have no idea where to go or what to do or who's right. And they
Yeah.
go
And
unread.
we, like we said at the beginning, our patients are smart. If they've done their job right and we've done our job right, they know why they're on hormones. They know the risks and the benefits. And I know it's scary to speak up to a doctor. I know that, but I do believe that the more educated you are, you'll be like, I'm on it for this reason. I understand there's risks, benefits, and controversies. And I've decided with my clinician that I will continue. And I think there's not enough of that happening.
I know I arm them with their talking points. I'm like, okay, you've had a DVT. This is what I want you to bring to your hematologist. Like, bring this. And then if they want to talk to me, they can talk to me. But
That's what
yeah,
I was saying. I'm like, have them call me.
yeah. Oh, well,
I don't
please.
see 25 people a day now. Have them call me. That's like, I'm literally here to be your advocate as this clinic that I've built because it's not just a 10-minute visit anymore. Like there will be people. And again, I want to arm you against Aunt Susie too. Like Aunt Susie still believes the WHI. So it's like that you have to be smart enough in what you choose. And I always say, I'm like, I never want somebody to say I'm on this because my doctor told me to. I
Oh, yeah.
hate that. I hate those words.
Yeah. Yeah. No, I
I'm
love
on
that
it
patients
because
will come in and
we
they'll
decided.
say like, "Oh, I was just at a mom's group and all these people didn't know anything about hormones." And I told them, like, hot flushes can hurt, lead to later life dementia. Like, just being able to say to people who are like, "You're on hormones," and then they say, "Yes, did you know this?" It's like it's so empowering.
Yeah, because it's their choice. That like, and there's like, that's just sexy.
Unlike ethics in general,
Unlike ethics,
which is not sexy.
owning what you're choosing to do with your body is sexy as hell. So do you think you're going to do more advocacy with this lawyer background? Like what's in the works, or are we
Yeah,
just working on 2025?
well, I know I am. I'm starting a new practice with a bunch of endosurgeons in DC. So we're going to really like just focus on pelvic pain. I mean, I'm going to do all the GYN stuff. So I'm really excited about that. I don't know. I love talking about it. As you could tell, I could probably talk all day about everything. I love also seeing patients. So I don't want to take away too much from that. But I'll just take. One of my husband's partners used to say I'm a pigeon lawyer, which means whatever the pigeon brings me, I'll do. The pigeon comes, I'll do it. So yeah, I love talking about it. I do feel like I'm in this weird role where I can at
I mean,
least
even
try
just
to be.
your ability to write like a lawyer, though, like has incredible power in like crafting advocacy and
You know,
rebuttals and
with
stuff
the
like
case
that.
with so much like it's just like an appellate argument. You see one case and you're like, oh my God, this is so bad, and let me distinguish it. It's the same thing with all these studies that we see right all the time. We're like, oh my God, it causes dementia, oh my God, and then we're like, okay, let's read it, let's see what it says, let's notice that it's observational. Like it's they're actually very similar, which I did not expect.
That's super interesting. I'm gonna give like one more shout out to like the menopause. I was meaning to like do a blog about this of like the uniqueness of the people in the space because we all love reading not just like clinical trials, but basic research. And I'm like, I've read more basic research in the last few years and like the level of understanding human physiology when you're like, and it's replicable in rats and it's replicable in the petri dish. And it's like, I have to think of these poor basic science researchers who like, they don't see patients ever. Like they literally do petri dishes in mice. And to them, it's such a no brainer that hormones help the nervous system and hormones
Yeah.
help nerves. Like there's reams and reams of data on how hormones help nerves and
And
brains.
we're such little nerds too. Like we love our little stuff. We're always like, I want to read this. Have you read this? Have you read this? Yeah. No, it's great. It's so empowering. I mean, there's so much good stuff out there. We cannot rely on something that's from 2001.
Totally. Yeah. I love it. Jen, thanks for sharing your brain and your magic. Thanks for doing
Yeah.
I don't think it's boring. I mean, I think ethics was boring when I went, but it was not more boring than statistics for
I
me.
always said that I was going to become an osteoporosis expert because no one wants to become an osteoporosis celebrity. I sort of feel that way about ethics. Like no one really wants to be an ethics celebrity. But I do think these conversations are important, especially as I see more and more people saying no.
I love it. I posted in the group today, just to go off on one final tangent, if we can, is that women are allowed to take off breasts and ovaries in the reasoning of prevention of cancer.
Mm-hmm.
And we see these women who are like, I love my estrogen patch. I need my estrogen. I can't tolerate any sort of progestin, including an IUD. I think the conversation is going to start moving to elective laparoscopic hysterectomy for these women.
Yeah, but also, Kelly, I was going to respond to you and I totally forgot to, but why don't, my mother-in-law, I should end on this because this is really interesting. She was one of the original scientists who worked on the Women's Health Initiative, which is like, I didn't even realize when I went down this path, but she has never been able to tolerate progesterone. She's 80. She gets an ultrasound every 3 months. And if her lining is thick, which it really has maybe only been once, she gets an endometrial biopsy or hysteroscopy. But she's never taken progesterone, and she does not have endometrial cancer. We can work with our patients as long as they come in for
I
their.
think that's a golden calf. I don't know if that's the right word or the right metaphor, but the set in stone that estrogen causes uterine cancer unless you oppose it with progestin is not true.
Well, it's not 100% by any stretch.
Exactly. So that's why you can't say estrogen causes uterine cancer because that means 100% of estrogen causes 100% of cancer in uteruses. And it simply does not. It is not true. Actually, like that's in my next coming book because I'm like, you need to actually see what the data shows. And yes, unopposed, higher dose, especially the synthetics, but low dose, a 0.025 patch, never been studied, never been showed to cause. And the other thing is endometrial proliferation does not mean it's going to turn into cancer, right? And
Yeah.
people
And
freak out.
I think it takes a year. I was trying to look this up because I was like, because sometimes I tell people, okay, if you're still having your period, you don't need to really worry about the progesterone. You're still shedding your lining. Something becomes strange if you go more than 3 months. Let's revisit it. I was looking to see how long you could go with an unopposed estrogen before we start to worry, whatever. And they don't even start studying.
It's years, right?
It's like, it's over a year of unopposed estrogen. Like it's, a month or a week. People freak out. And our perimenopausal patients, oh my God, I've got to have progesterone. No, you're still shedding your lining. So it's not crucial if you don't tolerate it.
Yeah, and that's the thing. Nobody said, like, the perimenopausal people who are still shedding their lining, first of all, never been studied, but certainly like biomechanically seems to be very safe, right? Because you're not building up, you're automatically shedding. And then, so I get these messages all the time on Instagram. My doctor took me off my hormones because I had some vaginal bleeding all the time.
Yeah.
And you're just like, oh God, cringe. So I think like we're turning it again, like the thought leadership, you get to kind of watch the river go by, right? And I'm like, we very quickly went from like hormones are fearful and scary to people doing hormones poorly, which makes us all cringe, but it's still better than no hormones. So like it is as cringy as we are with like, oh my God, the river's moving.
Yeah. Oh, well, it's been right. When I first went to the menopause conference, I think it was like 400 people. How many people were there last year? I don't know, 1,600 or something.
They sold out.
It's incredible. And yeah, right. The rooms are already sold out. I don't even the conference is sold out for this year, but it's great. I never thought that, I never thought people would be so interested in menopause, and I love it. It's great.
Dude, Gen X.
I know. No, it's true.
It's Gen X.
Yeah.
Yeah, 100%.
Well, it saves me a lot of time because I don't have to sit there and persuade people. It doesn't cause breast cancer. Like it's kind, maybe I can do my appointments 15 minutes. Everyone's like, have you heard of Mary Claire Haver?
Yeah, I'm like, dude, my podcast and my book, they make your clinic a lot.
Yeah, thank you.
Because they just come in there, like, give me all the things.
Yeah, love it. I know.
Right?
Thank you.
Like they're educated people, and it is an absolute pleasure to work with them.
Yeah.
Jennifer,
great.
the people in DC are lucky to have you.
Thanks. This podcast is life-changing. I just love everything that you do.
Thank you. We get feisty and we watch the river move, basically. We mix our metaphors.
I love that.
We try to have a good time. Hold on. There is a conference in DC in 2026.
Which one?
I mean, I'm sure there's a million of them, but there's actually one I'm interested in. Is it ISHWISH?
The Bone Health and Osteoporosis Foundation? That is a fun one.
No, it's just is it NAMS 2026 is in DC? There's something in DC.
Well, I know ISWISH.
Oh, American Urological Association.
I'll
see you there.
I know. Oh, you kidding? I love that stuff because everyone's peeing on themselves. I'm always like, you should not be
urology for everybody.
You should. This is one of my 5 golden rules: no peeing on yourself. Yeah.
Excuse me, here's another ethical. God, we could talk forever. If we have 2 association studies, so these are not strong studies, they're association studies, looking at women who are on testosterone have less stress incontinence, and we have 0 other medical, we have surgical, but 0 other medical options for stress incontinence. Why are we sitting on our hands with that?
I don't know. I'm behind on that one too. I need to start doing that for my patients. Is it you mean vaginal or
systemic?
Systemic, really?
Yeah, with the theory being likely increased core muscle mass.
I love it. No, I think because testosterone's not going to hurt you as long as you're making sure you don't get into 7,000s. It's worth.
So testosterone of 7,000 is bad for any gender.
Right? If you're watching it and not giving people these super physiological doses, like try it. It's not going to hurt you.
That's the whole thing, and it's cheap. You might have to lie to your insurance company or pay cash.
You can make your male partner get it for you, and then they just they get it for free.
Yeah, it's pretty darn cheap for sure. I mean, that's okay. We're gonna freaking end. I promise it on this one, but I'm very excited for there to be an FDA approved female testosterone product. Very excited. I'm cheering on everybody who's doing it because it's going to normalize this conversation. And then number 2 is, but if it's $400 and in a pink box, I'm still going to use the cheap shit that I'm still using.
100%. No, if people
it'll normalize the conversation though.
Yes, but if people are on these medications forever, they have to be cheap.
I'm planning on 40 years. Post-menopause would be nice. Can I be on these hormones for 40 years? Yes, please.
I tell the joke that I told my sister to crawl into my coffin and put my estrogen on me in case I'm a little bit alive.
Like the neurons need the final whiff.
Just that little final.
The final little bit of moisture.
No hot flashes in the coffin.
I love it. All right. Well, we'll let people know where to find you in the show notes. And thank you for coming on. This has been. I hope if anybody's stuck on this long and think we're as good enough time as we think we are, we've got at least a couple of fans. Yeah. If you're still here, we love you. Thank you for taking a ride with our tangents. All right. Till next time. Thanks, Jen.
Okay.